Hyperglycemia in pediatric patients. Children and young adults are much more commonly diagnosed with type 1 diabetes and are therefore susceptible to DKA, a life-threatening event. However, you may encounter either type 1 or type 2 diabetes in the pediatric patient population. Children are at varying stages of cognitive development, so maintenance of blood glucose levels within the normal range can be challenging. Further, a low socioeconomic status is associated with an increased incidence of DKA, poor blood glucose control, and lengthier hospital admissions. It is therefore essential that the family be involved and supportive to increase compliance with medications and diet interventions. Let's quickly review the pathophysiology of hyperglycemia in type 1 and type 2 diabetes. Type 1 diabetes is thought to be caused by an autoimmune reaction where the body attacks itself by mistake. This reaction destroys the beta cells in the pancreas that make insulin. This process can go on for months or years before any symptoms appear. On the other hand, with type 2, there are three major metabolic defects that contribute to hyperglycemia: increased hepatic glucose production, impaired pancreatic insulin secretion, and peripheral tissue insulin resistance. Remember that after eating a meal or ingesting glucose, insulin is secreted, hepatic glucose output is suppressed, and insulin-dependent glucose uptake by peripheral tissues is stimulated. In type 2 diabetes, insulin resistance and impaired insulin secretion inhibit normal suppression of hepatic glucose output. As a consequence, the liver continues to release glucose into the circulation. Moreover, peripheral insulin resistance coupled with insufficient insulin results in decreased uptake of glucose by insulin-dependent target tissues, notably skeletal muscle and adipose tissue. These mechanisms contribute to hyperglycemia in type 2 diabetics. Let's quickly review the signs and symptoms of diabetes type 1. You've got an increase in urination, increase in thirst, and increase in hunger. All at the same time, the patient's experiencing weight loss, fatigue, and increased frequency of infections. This is rapid onset, and it results in insulin dependency. There's usually a familial tendency. And your peak incidence is going to be from 10 to 15 years. We all know that hyperglycemia is the abnormally high blood glucose level. This can be a new onset or a complication with a known history of diabetes, but either can result in severe dehydration and DKA if not properly recognized or promptly treated. Both are potentially life-threatening. During your assessment, you will typically find one of the following has occurred. The dose of insulin was missed. A greater proportion of food was eaten compared with the dose of insulin, or the insulin pump malfunctioned. Remember, when checking blood glucose level on a baby, make sure you take the reading from the heel. Assessment of known diabetics. During assessment, ask about the following: insulin administration, functioning of insulin pump, changes in urine output or changes in mental status, patterns of recent glucose checks, and the presence of urine ketones if the family's checking those, or any other signs and symptoms such as a headache, visual changes, seizure, abnormal speech, or the presence of vomiting and abdominal pain. Treatment for hyperglycemia. Provide 100% oxygen or assisted ventilation if needed. Monitor vital signs closely. Obtain IV access and administer isotonic fluids such as normal saline or lactated ringer. A 10 milliliter per kilogram Bolus may be administered for shock. Repeat as needed to maintain adequate perfusion. Up to 40 milliliters per kilogram total infusion. The risk of cerebral edema with rapid IV fluid administration exists. Run IV fluids slowly during transport if needed. For example, 20 milliliters per kilogram over an hour. If patients report worsening of headache or mental status deteriorates during fluid administration, discontinue fluids immediately. Assess and treat for increased intracranial pressure from cerebral edema and impending herniation. Closely monitor ABCs. Be prepared to adjust treatment accordingly. Electrolyte imbalances, particularly of potassium, may lead to ECG abnormalities and dysrhythmias, so closely monitor the ECG. Patients in DKA desperately need insulin. However, this is not a drug that is administered in a pre-hospitalized setting. So if the insulin pump is working, do not discontinue its use. Immediately transport to the closest appropriate facility. In summary, patients with hyperglycemia desperately need insulin, but you as the provider do not have access to this drug. So your best option is to give fluids, but this is not without risks. So monitor your patient's ABCs and other vitals closely. Ultimately, your best bet is to transport rapidly.